LGBTQ Commission. I just want to let people know that this meeting, being a public meeting of a work group from a state agency, will be recorded and is being live streamed on YouTube as well. So that way we encourage public participation. As all of you who are here today should know by now, this is a work group on HIV access, HIV medication access, and how to address three particular issues that the legislature asked us to address. We come to this space knowing that we have different ideas, different hopes, different understanding of the work, and even different interpretations. And we'll go into that in a second. But right now, I want to welcome each and every one of you for taking the time this Monday morning to be in community together, trying to envision new ways in which we can engage the community that is living with HIV in Washington and provide for them and for all of us the best care possible and the best and easiest access to HIV medication in this case. We recognize that we are on indigenous lands. I myself am on the Puyallup and the ancient lands of the Puyallup people, and I come from the land of the Taino and the Caribs. And with that, we also recognize that we, in everything that we do, not only recognize our ancestors and ancestors that have taken care of these lands, but also how to move forward in justice and in reconciliation and recognizing our place in restoring these lands to the inhabitants that have taken care of them for generations. So with that, friends, I invite Omar, our program manager at the commission, to walk us through some of the important things that you have to keep in mind as we engage in conversation this morning. Omar, take it.
Thank you, Manny. Thank you, everyone. Omar Santana, project manager for the commission. Like I mentioned before we recorded, that we are recording this event for future reference. If you need to protect your identity or for any other reason, please and choose not to be recorded, you can end your participation at this time. In order to foster healthy and safe interaction, if there is any disruptive behavior, the participant in question will be notified by commission staff about their behavior. If they refuse to comply with health and safe interaction guidelines, they will be removed from the meeting. Healthy and safe interaction includes assuming positive intent on the part of the panelists, moderators, participants, and staff. Do not use transphobic, homo, lesbo, biphobic language, misogynistic, xenophobic, racist, anti-Black, ableist, ageist, or foul language during your interactions. Focus on comments on the issues at hand. Focus your comments on policy matters. Name calling or insults are not allowed. And again, I am also the background administrative support for the meeting. So if you have any issues with your connections or need any assistance, please feel free to send me a message in chat and I will be able to assist you with that. Back to you, Manny.
Actually, I think that is Martha's time. You're muted, Martha.
I would think I would know not to unmute. Manny, and it could be my time, but I think we thought maybe you'd launch the meeting this time rather than me doing the agenda review.
Oh, okay. Oh, yes, I see it here on the agenda. Thank you. You know, folk, you would think that we have everything quite ready because we meet so often just to make sure that we have the best time and that we use your time wisely and good. So you would think that all of this is already you know, in our minds, especially as we just met an hour ago. So thank you, Martha, for reminding me this. So folk, last time, for those of you who didn't have the chance to be in this group last time, and for those of you who, you know, enjoyed the week so much that you forgot what happened that time, but last time that we met, we wanted to share with each and every one of us some things that we have learned, especially in that moment before we came together as a group. I share with you some facts, some things that I have heard through my lens, obviously, and my interpretation of some of the things that you have shared with me, some of your concerns, some of the things that we have learned as we came to this group. And since then, we had the big meeting, the long meeting, where we share some more ideas, some more facts, some more feelings, some more perspectives. And because of that, we decided, and because of the wonderful feedback that we received, having shared these facts and issues as we entered the discussion, we wanted to continue with that tradition so we could put everything out there and have a transparent process. Now, I also want to highlight that these facts are through my lens, right? As we have engaged in conversation with feedback from the facilitators group. So it's my lens through, my lens and what the facilitators have also given me as a feedback. And also, these are not accusations of any kind. These are not, pointing at people or anything like that. These are just things that we have heard. I also want to say that oftentimes we are going to hear things that seem to be contradictory. And that's because we are a large group and we all have different ideas and different perspectives. So if you feel like, oh, what Manny pointed out there feels very contradictory to what he said later on, that is because two realities can be, two different things can be reality at the same time for different people. So keep that in mind as I read through these, and we'll use these as well as we enter into more discussion and conversation. So with that, I will make these public at a later time on our website, but for now, we wanted to also take away from the time to read and all that, to offer you just the opportunity to think about these things instead of just taking notes about them, but just to think about these things. So with that, there were 7 follow-up facts and issues and conundrums that we recognize and we want to share with you. The first one, access to quality care for people living with HIV is still the main concern of all stakeholders and partners. Access to quality care for people living with HIV is still the main concern of all stakeholders and partners. The second, not everyone is in agreement on what constitutes quality care or how it should be measured. Again, not everyone is in agreement on what constitutes quality care or how it should be measured. Third point, the lack of participation from people living with HIV, as well as from healthcare providers, is still a concern for all participants and stakeholders. Again, the lack of participation from people living with HIV, as well as from healthcare providers, is still a big concern for all stakeholders. The next one. Most participants have expressed or shown discomfort or concerns with the pace of the process, some feeling it too slow and some feeling it too quickly, depending on our different lens. Again, most participants have expressed or shown discomfort or concerns with the pace of the process, with some people experiencing it too slow and with some people experiencing it too quickly or going too fast. The fifth one, passion in our positions and our ideas can at times be misinterpreted as personal attacks or as questioning the integrity or the professional ethics of participants. Again, passion can at times be misinterpreted as personal attacks or as questioning the integrity or the professional ethics of participants. The next one, envisioning creative solutions focused on the future and addressing concerns of all partners continues to be a challenge. Continues to be challenging, sorry. Again, envisioning creative solutions focused on the future and addressing concerns of all partners continues to be challenging. And the final one, participants are building on past experiences and interpretations of work. It is perhaps time to move past this and co-create new realities. The final one, participants are building on past experiences and interpretations of work. It is perhaps time to move past these and co-create new realities. And again, friends and partners, this is not criticism. This is not pointing fingers. These are just things that we as a facilitator team have seen through our lens facilitating this group and these conversations. And we are also hopeful, and I have to say this, because Martha and I discussed this on the last time that we met. We're also hopeful because we have seen many great ideas and many great suggestions on how to move forward. So these are just the hard facts and sometimes discomforting facts about the work that we do. And parallel to that, we have also seen a lot of great ideas that we're going to start integrating, and you're going to hear about those as the meeting goes on today, because we want to share with them. We want to share them with you and get some feedback so we can start creating the report that we have to submit to the legislature. So thank you so much for all of your work, and thank you so much for taking the time to be here, and thank you so much for being brave and actually engaging in these difficult conversations. We're ready.
Okay. The baton's back in my hand, I guess. So for those of you who joined in the last 5 or 10 minutes, you may notice many of us have had the opportunity to put in both our preferred pronouns and our affiliations in our name. If you could go ahead and do that, if you haven't already had that chance, please do. Given that we're not going to do a round robin of introductions like we did last month, this will help us all to really know who we are. With that, I'm going to go through the agenda and what we hope to really achieve through each part of the agenda. And as I begin this, I'd like to give a great thank you to really underscoring what Manny just said, for those of you who are all willing to have these hard conversations, and also to many of you who've prepared information for today, some of which we know about, some of which we may not. And for all of those who went ahead and took a look at the documents and gave them a fine-tooth comb. Again, I don't know all of you who did that, but I'm assuming more of you did that than I actually heard about. So with that, the purpose of today's meeting is to learn about and discuss information that was requested at our last meeting. Based on that information, and also based on your own understanding of the issues, we'll continue to identify and add context and content to topics that should be addressed in the report. And we'll talk about how we're going to coalesce that report together. So that's the purpose of today. We'll also do a little bit of readiness for the town hall meetings that are coming up. You may remember one was originally scheduled for last Monday, and we all decided that the Monday after Labor Day weekend was probably not the right time to do a town hall meeting. So it's been postponed, but with a lot of good preparation for September 20th. What we'll do next is we have 4 different topics that your facilitation team felt people really would like to have more information on. And we're going to approach each of these a little bit differently because we have different kinds of information that will be brought to each of them. First of all, people really want to understand the cost issue, especially given that that's part of what the legislature asked for, and given that cost is confounding. And so we'll talk about that a little bit. And I know a couple of you may have information to bring. If you have slides, just let Omar know, and he'll make sure that you are able to share your screen. The next topic is the experience of other states. There was a theme from the last meeting where people said, well, gee, how have other states solved some of these problems? We know every state is different, but still there must be similar challenges in some other states. How do they get through this? How do they manage this? And what are the experiences in those other states? And to the extent that we can understand it, given that people measure things differently and given that there are different cost constraints associated with how care is delivered in each state, what are some lessons we can learn from other states that might have applicability to Washington state in moving towards, as Manny said just a moment ago, creative solutions to what people understand to be the issues and problems here? And people were very interested in understanding rebates. What a complicated problem. Many of you, or it's not a problem, is that right? I'm supposed to say a challenge. Many of you have been involved with rebates for years and years and years, and you know them upside and downside, and you also know then how complicated they are for even the very involved layperson. So again, in order to address what the legislature asked this work group to consider with the LGBTQ Commission is more information on rebates. I know we're going to have some presentation material on that, and I thank a guest that I believe we'll have today, Christina and Devin, to help us with that discussion. The last thing is the meaning and measurement of both efficacy and access. Manny alluded to this in his 7-point observations that he's talked about, gee, what is quality care? How do we know what quality care actually is? And so we'll talk about that. For the first of these information presentations or conversations about what can we actually do to understand cost, and for the final one, the meaning and measurement of both efficacy and access, I think we'll also use our Q&A time, which we would like to focus on facts and clarifying questions. We may, on the first and fourth topics, also segue into some of the brainstorming work that we expect to do after the break. So, then we'll have a break after we get information. And during the break, I'll ask you to think about the questions that are actually in the agenda. And so we don't have to go through those now, but you're welcome to bring up the agenda and take a look at it, and know that we will have, we hope, the better part of an hour to start adding content and context to the report. Then we'll do a wrap up. We'll talk about the town halls, key points and take-home messages from this conversation, and talk about what we're going to do at the next meeting. Are there any questions about the agenda? Okay, I guess it's crystal clear. All right, so let's begin by talking about how can we actually understand cost. And as I was querying some of you between the last meeting and this one about getting a handle on cost, one of the things that Donna Sullivan suggested was that she could offer some information for us on relative costs. Well, she's confidentiality agreements, I think I'm getting that right, that it's confidentiality agreements, prevent her from giving actual costs. She can offer relative costs. So she's going to bring that up. And I would encourage you all to think about what are some of the interesting questions that what Donna is going to present to you evoke for you, and let's ask those questions. And then I'd also like you to think about, so if relative cost is one way to think about cost, are there some other ways to get at that question of cost? Are there proxies? Are there other ways to think about it? Donna, do you feel ready to offer us your information?
Sure. So I did actually create a few slides, Martha, so I don't know if you want me to share. Okay.
I think that'd be terrific. And Omar's going to allow you to share, I believe.
Okay. And let me just bring up, hang on, I got to figure out which screen I have the slides on.
I have to say, I'm always admiring of people who have backgrounds like that. That's impressive.
Okay, now I have to.
Oh, while Donna's bringing that up, one other thing. Omar does have the chat room open. If you remember, the chat is public. So even if you just send it to one other person, because of the way this meeting works, ultimately it will be available to everybody. So don't think of it as a back channel.
Okay.
But Omar will keep track of the chat. And when we do Q&A, if you prefer not to raise your hand by using the little hand icon down below, but by putting it in chat, he'll monitor that for us and bring it up. Okay, Donna, take it.
Sure. So I just wanted to give some overall Medicaid drug expenditure. And so this is looking at the fourth quarter of 2019, the first quarter of 2020. It's older data. I didn't have time to pick new data. But I just wanted to look at our top 10 classes, by net paid. So antipsychotics, HIV drugs, ADHD medications, cytokine and CAM inhibitors, which are like rheumatoid arthritis drugs, things like for psoriasis, substance use disorder, anticonvulsants, respiratory agents for cystic fibrosis, oncology agents, multiple sclerosis agents, and then in general HIV medications. So these are the top 10 drug classes that Medicaid, spends money on. And this is all of Medicaid. It's not just the Medicaid fee-for-service program. And then I wanted to look at the top 25 drugs, and I'm not going to name them all, but they're, again, mental health, HIV, it's basically a myriad of the drugs that are contained in those top 10 classes. So I just wanted to share kind of where we're coming from when we're looking at cost and utilization. We're looking at, where are we spending our money, and what can we do in order to kind of manage that. And I'm hoping that this link works. It is. Okay, it may not be working. So I have another. I have it up right here. So I'm hoping you can see a spreadsheet now.
We can see it, Donna.
Okay, great, thank you. So what I did is I took the net cost, and if I scroll down, you can see the key. I took the annual net cost after all federal and supplemental rebates were accounted for. And then I made this kind of spreadsheet to look at the drugs that are listed in these columns. So hang on. And I basically focused on the single tab regimens, because I think that's what, the conversation is really about. So I looked at the single tablet regimens across these columns and then calculated their relative costs to the drugs listed in these rows. And these are our preferred drugs here, or preferred regimens, I should say. And then the bolded drugs are the preferred single tablet regimens that do not require prior authorization. And so $1 sign means there's less than $1,000 difference, and it's either positive or negative from the drug listed in the column to the regimen, the entire regimen listed here. So if it's 2 drugs, it's the cost of both drugs compared to the 1 drug across the top. $2 signs is $1,000 to $499. 3 is $5,000 to $99.99. 4 is $10,000 to $14,999. 5 is $15,000 to $19,999, and then 6 is more than $20,000 difference. And yes, there are some that are 6, I believe. So, I mean, this is just it. So when we look at a tripla, this means a tripla is whatever I just said, 3 equals. Sorry. So a tripla here would be $5,000 to nearly $10,000 less than this particular regimen. So Prescobix plus Truvada. We come over here to Biktarvy. Whoops. I don't know what just happened there. That's another spreadsheet that I had to share. So Biktarvy is $5,000 to nearly $10,000 more than this particular, these 2 drugs combined. And that's kind of how you read this. So Delstrigo would be the $1,000 to $5,000, difference. And I don't want to go through all of these, but this is just the table of the relative costs.
So Donna, a quick suggestion. If you go to the menu up top where it says file in the upper left-hand corner, and then there's an up arrow in the lower right-hand corner of that, you can actually, please, I said I didn't want you to click on file, but
Okay.
to go in the up carré in the right-hand corner of the menu bar, we can see a little bit more of your spreadsheet. You can collapse that.
Are you talking this
There
one?
you go. The
Okay.
one above it, right above it. Right above it, that one.
Okay.
There you go. Now we can see a little more. Donna, how many more do you have? You have 2 or 3 more?
Well, this is the one, and then I have the other spreadsheet that popped up. It kind of addresses the other question, but this is a study or an analysis that we did and shared with the legislative staff. Was we took a weighted average of the multi-tablet regimens compared to the net cost of the single tablet regimens. We did a weighted average, and we tried to figure out how much it would cost if we switched from the multi-tablet regimens to the single source tablet regimens or single tablet regimens. And depending on the percentage, it goes from $1.3 million to potentially $13 million in state funds, or $6.3 million to $63 million in overall costs. So this would be federal, state combined. And we can go more into this when we do it, like what are the states doing? I have information on that. So this is what was shared with the legislature. So when you hear me, saying, 40 to 60 million, it's based on what we think that shifting would be. And we think it would be somewhere around the middle amount. This table here, if you're looking at it, is the multi-tablet to single tablet when we excluded Truvada and Descovy individuals that we assumed were using Truvada or Descovy for PrEP. And then this table here is switching from Truvada to Descovy. These 2 tables combined make up this one here.
So Donna, the reason I asked is I think people are going to be interested in digging down a little bit and doing some Q&A into your first spreadsheet. I know they will with the second one as well. Before we do that, I'd like to do a cross-check on you noted kind of right out of the gates that you think what this conversation is really about is, should we move to a single tab regimen, or you said it's really about moving from multiple to a single tab regimen. I wonder if we could just focus on that for just 3 or 4 minutes. Do other people share that perspective, that that's what this is really about?
Martha, the reason why I say that, and just to give some background, is those are the only ones that are on prior authorization. So I'm assuming that
okay.
Since we're talking about prior authorization, that's the drugs we're talking about.
Okay. I mean, no accusation here, just, wow, maybe this is it. Maybe this is what we're talking about. I'm looking for commentary, folks. Let's have a little bit of feedback here.
I see Eric has his hand raised.
Eric.
Yeah.
Hi, thank you. Donna, this is great. Thank you for putting this together. So my question on this spreadsheet that's up is, there's a lot of information here, and what I think we're looking at is what is the change from switching from the from the single tab to the component of that single tab, right? The component medications in the multi-tab. And I'm not a doctor and not a pharmacist either, so it's a little confusing to me to know, like, what, say for example, Atripla, what are the component drugs? So I'm wondering if there's a way to highlight on the spreadsheet sort of the comparison between the single tab and its component parts, if that makes sense.
Yeah, hang on just a second. I need to pull up another spreadsheet because I don't have them memorized off the top of my head.
Understandable.
And Donna, as he's doing that, again, thank you for putting in time you didn't expect to have to add into the last 2 weeks, amalgamizing this information. And then
Yeah,
we
thanks,
have
Matt.
Dale with
Great.
a question for you too. Thanks for the thanks, Eric. Okay.
Yeah, yep. Yeah, hi, Donna. Yeah, thank you for this, Donna. This is actually something yearning to see. And I think, you know, I would like to see with it, though, also as a consideration that, like, you know, when are the patents off some of these single regimens? Because it's a gap analysis maybe of when our budget as a state could actually be, you know, right now we need to float a little bit more because of these single, because that's really, I think, where we're at with, we've evolved to have single dose regimens, which are more costly. And so when are those patents coming out? Because then maybe we can have ascertain some, when does the cost come down so we can represent, you know, when that actually budget impact comes down. And then, because the generics might be available. So, but no, thank you for that wonderful work there on that.
So sorry about that. Some of them have gone off patent, and I don't remember exactly which ones have. I would have to look. I have it, I think, in one of my other slides. So the efavirenz emtricitabine has gone off patent, and the efavirenz lamivudine and one other drug, I forget the third one, it's not on my slide, it's too big, went off patent. And I want to say one of them's Jaluca, but I don't quote me on that. The drug companies, Christina and others might have a better sense of which ones have gone off patent. But going back to the question of what is what, so a tripla is efavirenz, tenofovir, DF, so TDF, and emtricitabine. So if you know them by their abbreviations, it's EFV, TDF, FTC. And so what we're looking at here is Prescobix, trying to find it, Pifiltro. Prescobix is darunavir with the Cobistat booster, tenofovir DF, and lamivudine. So what we're looking at here is Prescobix, which is darunavir, rather than the efavirenz. So the difference between a tripla and this combination is Prescobix has the darunavir in it. And then Truvada is the emtricitabine, tenofovir DF, which is the same, that's in a tripla.
So one thought, Donna, I'm wondering if two things. One is this information that you have easy access to, or could we involve someone else to help think about both when things go off patent and also what actually are the component pieces that Eric was speaking of, and that's information people would like to have. It's not clear to me we should use our time today to go into that detail right now, but maybe we can enlist some others to help you out to add that information. And if it's not possible to get all that information, then maybe that's one of the things that goes into your final report is let's have this fuller understanding of each of these drugs. Manny, do you want to add anything to that?
Yeah, so I had commented to Martha as Donna and Dale and Eric were having a conversation, that perhaps some of the ideas that we're generating on how to navigate this information can be part of the report, right? Because the reality is that I mean, I'm also a state employee like Donna, and I know that we don't have all the funding to be able to have the people to do these sort of things, you know, immediately. And perhaps that's one of the things that we can tell the legislature, hey, there is this need to navigate this data, and we need funding to have people ready do these sort of things, so they can provide that easily to the community when requested, and do the work also for the scientists and the pharmacists and the people on the HCA and DOH who work on this issue. So I just wanted to point out and that through these conversations, we might not have all the information right away, but that is part of what can go into the report and the request to the legislature to attend some of these needs. So I just wanted to point that out, because we are doing the work. So we're hopeful, and we can already see some of the ideas that will be part of the reporting.
Other questions for Donna or really for anyone else on this topic?
Melanie has her hand up.
Well, good morning, all, and thank you so much for all of this information, Donna. I have a question about the second table that you just showed, where the Healthcare Authority was predicting the uptake or the switch. And I think you said something, it would be like the middle of that table. So the 70% range of folks would switch from a multi-tab to a single tab. Can you maybe give some background about how that number was developed? I'm curious about that figure, about how you came up with 70%.
Okay, so Martha, I'm gonna go back to one of my other slides that
Sure.
about what the other states are doing. And so let me, not sure which slide it's on. Okay, I'm just gonna, okay, what other states are doing? So this slide here, I have several times, about once a year, reach out to all of the 50 states to figure out how they're managing this class. 28 states have HIV medications on their PDL. 21 states don't prefer all HIV medications. 16 states have PA on single tablet regimens. 23 states, including DC, do not have HIV on their PDL. 11 states have legislation prohibiting management of HIV. Most of those were passed in the 90s. Vermont recently repealed its prohibition. 10 states do not have legislation prohibiting them from managing it, but they choose not to manage it, or they prefer all of their products if they're on the PDL. And then I asked recently about their legislation or their utilization. I didn't get much. I didn't have a lot of time, so I haven't had a lot of responses, but the range anywhere from 10% of their entire HIV medication utilization was in single tablet regimens, up to as most as 91% of their HIV medication had switched to a single tablet regimen. And then the mid range was about 65%. So that's where I came up with, I think it's going to be, at least 50% is going to, our utilization will be at least 50%, and possibly as high as 90% or 100%.
So Donna, you and I talked last week as we were thinking about these numbers, that you knew some people were going to have some questions for you about that, and may have different experiences or different numbers that they'd like to share with you about that. I think we talked about that anyway. I hope we did.
Right.
Melanie, or do you have more that you want to comment on that, or trying to think of the others I heard from who were wondering about that switch percentage?
I do. Maybe another of the panelists will be able to answer this question. But I think, one of the things that I'm curious about is, this is a process. So, Washington State has a process for converting from a multi-tab to a single tab. And so I think, a better understanding maybe of how other states' processes match up to get to this range. In other words, if they might have a PDL or they might have a prior authorization requirements, but how do those requirements stack up in compared to ours for the purposes of judging this number, right? So I guess maybe some of the other questioners will answer this. But I just would like a little bit more clarification about, and that might be an apples to automobiles comparison, but that's thank you very much for answering that question, Dawn. I appreciate that.
Well, and Melanie, part of my role here is to say that the reason we want to know all this, or want to have a better grip on understanding this, is because if in fact it's how much of a big chunk of money it would be for the state to change how this works is a key feature of this whole discussion. So what that percentage is and how you all get to that percentage, it isn't just an intellectual argument. It's something that says, okay, so how do we understand how much this is really going to cost? As I recall, someone else, and forgive me for not remembering who among you it was, also said there are 2 points in an individual's treatment where they might switch from multi to single. I believe someone described it as prep versus treatment. I wonder if there's more to say about that. And I'm a neophyte to this, so I may have had the words wrong. And Jonathan has, I barely see your pronouns, but I see that they are his. So thank you, Jonathan.
Thank you. You started saying exactly what I was going to say, Martha, which is that this is a critical piece of information, the shift percentage. And I think that it would be valuable for this group, I guess, to know a little bit more about the research or the what went into that estimation, Donna. So you mentioned that you reached out to states. Sounds like you were in a bit of a time crunch. It also sounds like not everyone you reached out to was able to get back to you. I'm wondering if we can know the data inputs to that, because again, I don't think that I'm nitpicking at just any piece of information. It seems like a really critical piece of information.
So over the last couple of years, here's another spreadsheet. I've asked the states what they're doing, and two new pieces of information I did was these 3 questions: was what is their percentage of single tablet regimens, what drugs they have preferred for PrEP, and whether or not it's a carve out. So I've either gone out to their website or they've responded back to me on what their PDL status is for most of the 50 states and the District of Columbia. So this is the data. If I get rid of the blanks here, these are the states that responded back to me. So Colorado doesn't have HIV on their PDL. They prefer everything, and they're at 58%. Idaho has drugs on the HIV on their PDL. They prefer 10 of the single tablet regimens. So the other 3 are on prior authorization. Though they're at 61%. Indiana prefers everything. They're at 91%. Maryland, they reported back to me the majority. So I just said greater than 50. Minnesota prefers everything. They're at 43%. Missouri, they have everything on, they have it on their PDL. They do have prior authorization on some of the drugs. They're at 21%. So they're managing, I think, pretty tightly. Montana has everything preferred. They're at 56%. New York, 82 or 80. Oklahoma, 82. South Dakota is 10. Texas is at 51.5, and Vermont's at 65. So this is where I'm thinking the majority of the drugs are in, the majority of the states are at close to 50% or higher.
So Donna, we have 2 people with hands up, and I got so interested in this, I didn't look at the time. And
Okay.
We have promised Christina that her people would be able to be out of here pretty quick. So Dale and Amy, if you could please hold on to your questions. We'll come back to them. And I want to just say a quick thank you, Donna, for allowing us to take a deep dive into your models, and to those of you who are doing the intellectual work to do the deep dive as well. Christina, can I turn it over to you? And my apologies to you and your team.
Thank you. So we were asked to do a primer on the laws and policies surrounding Medicaid, surrounding our manufacturer participation in the Medicaid program. Because these laws and policies apply to the entire biopharmaceutical industry, we thought it would be best to bring in a third-party expert to do this. So that expert is Artia Solutions, and they're a consulting company dedicated to taking the complexity and hassle out of Medicaid policy and drug reimbursement. And they've prepared a few slides that hopefully they can show. We'll simplify this for everyone.
All right, Christina. Christina, I'll take it from there. My name is Chris Andrews, and I'm representing Artia Solutions today. So Omar, I do have a few slides if I could share my screen.
Thank you, Chris, and you should have access now.
Okay, thank you. Okay, somebody just give me a shout to let me know I'm successful.
Yes, it looks like your slides are showing.
Great, I see some thumbs. Okay, as I mentioned, I'm representing Artia Solutions today, and we are a paid consultant by pharmaceutical manufacturers to assist with Medicaid access for pharmaceuticals. So Gilead has asked that we step in today to talk about the nebulous area of the Medicaid rebates. My qualifications are that I worked for a Medicaid pharmacy benefit manager for 17 years, and my responsibilities there were to help state Medicaid programs conduct their preferred drug list programs. And that includes supplemental rebate negotiation and net price analysis. So what I'm going to do is spend about 5 minutes walking through 5 slides to talk about the Medicaid rebates that dictate the financial component of the value that is evaluated when making preferred drug list recommendations. So to start, I have the 2 primary rebates listed here, statutory and supplemental rebates. And I'll get into both of those in more detail, but I want to call out the part at the bottom first. And I should also mention that I have been through the minutes of your work group's meetings, so I hope to address the major concerns under the rebate and financial portion. This is one of those where I reference 42 USC 1396 R8. That is the part of the federal law that protects all of the contracts around rebates, whether statutory or supplemental. So to answer the question about why all the confidentiality, this is why. It is subject to US code and cannot be disclosed without specific permission.
Chris, this is Martha. If you look, excuse me for just a moment, if you could do something similar to what Donna did and take the upward facing carré in the right hand side of your toolbar, and then you can and collapse the toolbar, and then maybe also down in the where it says 64% on the size. If you go to the thing that is the full screen, then some of us who are looking on little screens will be able to see your slides a little bit. Actually, I'm thinking of to the left of that, to the little icon that is the there you go. That makes you click on that and you get the full screen of the slideshow. There you go. Thank you so much.
Sure, thank you, Martha. So everybody can see this well now. So the code that I'm referencing is at the bottom there if you'd like to check that out. Next, I'd like to start talking about the Medicaid program in general regarding the rebates. First of all, the Medicaid pharmacy benefit is an optional program, although all states and the District of Columbia elect to opt into it. So all states are providing pharmacy coverage, and these benefits are shared in terms of the expenditures between federal and state governments by a certain percentage that is at a minimum 50%. So at least 50% of the pharmacy benefit is funded by the federal government. Now, when it comes to which products are covered, reimbursed, paid by the state Medicaid program, That's determined by the manufacturer's participation in the Medicaid drug rebate program. And that's been in effect since 1990. So the manufacturer must sign a contract with CMS, Centers for Medicare and Medicaid Services, that guarantees that that manufacturer's products will be covered, reimbursed, whatever terminology you use, they will be covered under Medicaid. If there's no rebate agreement, then there's not going to be Medicaid coverage, most likely for those products. So manufacturers, if they do not participate, then their products are not going to be reimbursed by state programs. However, the footer here says that states can cover those drugs. However, they would not receive any federal participation in paying for them. So the vast majority of manufacturers do participate in this Medicaid drug rebate program. The utilization in Medicaid that is applicable to these to all these rebates is total. So regardless of whether a Medicaid recipient is participating through fee-for-service or through managed care, their pharmacy utilization can be invoiced for the statutory Medicaid rebate. And the way the process works, another part of the work group minutes that I saw, the process flow is that a state pays for a prescription to the pharmacy. So the state reimburses the pharmacy. Then at the end of each quarter, the state will take a record of all the utilization that was dispensed over that quarter, and they will invoice manufacturers for the statutory rebate and for any applicable supplemental rebate that we will discuss further. Now, the statutory rebate is made up of two components. So we're getting a little into the weeds here, but not too far. The first component is the base rebate. So by signing that agreement that I mentioned between CMS and the manufacturer owes 23.1% of the gross cost of any pharmaceutical. So you'll see here that's represented by AMP. AMP stands for average manufacturer price. So that's the gross cost that is used in the calculation to determine the base rebate. So most products are going to be subject to this 23.1% discount. Now, one of the benefits to Medicaid is that it receives best price. Best price means that a manufacturer has reported to CMS its highest discount outside of government programs. So the benefit to Medicaid is that if a manufacturer enters into an agreement for, let's say, a large corporation XYZ, and gives them a large discount, that discount flows through to Medicaid. So now instead of 23.1%, you receive whatever discount exceeds 23.1%. So the base rebate can grow. The other component of the statutory rebate is the inflationary rebate. And this grows by a penalty that is assigned to a product based on the increase in the cost of that product versus the consumer price index, or CPI, specifically the CPI-U, which is the consumer price index urban rate. So if a manufacturer increases the price of its drug over the rate of inflation, a penalty is applied to the statutory rebate, a penalty that benefits Medicaid. It's a penalty to manufacturers. So going back to best price, the best price benefit for Medicaid is that the government always receives the best discount available. However, these specific Medicaid rules for discounting means that we cannot combine programs. So I saw some other programs listed, ADAPs, 340Bs, those kinds of programs. The pricing is different for those, and they cannot be leveraged with Medicaid. Now, in addition to the statutory rebate, there are also supplemental rebates. Supplemental rebates are optional rebates that manufacturers can negotiate with state Medicaid programs. So these are typically negotiated by the pharmacy benefit manager companies, and those companies will assist states in operating their preferred drug lists by negotiating these rebates and contracting for them. As I mentioned, they are voluntary, and manufacturers will compete within a PDL class based on a number of components: clinical effectiveness, safety, also net price for their pharmaceuticals. And that generation of competition likely leads to selection of products as preferred or non-preferred. Now, the manufacturers, their offers that they submit to be determined in coming to the net price component of value, that can also include different language that talks about the access granted to them, such as being a limited number of preferred products, or as having different access than open access. Perhaps prior authorization criteria would be permitted through the offer. Those can vary. Important note under number 2 here is that these pharmacy benefit managers do not retain any Medicaid rebates. They may work for the state, but they do so on an administrative basis. So unlike in commercial, where you see that a number of rebates have been retained by the PBM, that's not the case in Medicaid preferred drug list management. And finally, I'd like to just show the net price calculation in Medicaid, starting with that gross cost or AMP or another metric. Subtract the statutory rebate, both of those components, subtract the supplemental rebate if applicable, and that brings us to the net price that is considered along with drug safety and effectiveness in coming to PDL decisions. And going back to the US code, these are the reason that these are kept confidential is because these are trade secrets of manufacturers. So as you can imagine, when we're talking about supplemental rebates, which is a discount that can be on top of the discount to in the commercial area, these can be very large discounts in Medicaid. So that needs to be protected as trade secret and is done so through US code. So at this point, I'm happy to take any questions, or I will be around later to participate in any further discussion on Medicaid rebates.
Okay, are there questions? Chris, how long will you be with us?
I'll stick around. I'll be here for the entire discussion.
What I'd like to do, with your permission, is dial back to, I know Dale had a question earlier, and I believe Amy did as well, to dial back to Donna's presentation. And then we're switching up the agenda, which often happens, and then let's go back and get clarifying questions, or we'll have questions and discussion around what you've offered and presented. Thank you so much for your flexibility. I really appreciate it. Dale, and then I think it was Amy. We're back to talking about the spreadsheets that Donna brought up, and if need be, Omar, I'm sure can allow you to share your screen again, Donna. Dale?
Yeah, boy, this is just I'm just getting awake in here, and thank you, everyone. So Donna, about the shift percentages, is there any kind of relation to those other states about how they're doing with treatment adherence and their goal to end HIV transmissions and such? Any follow-up data to that? Because that's, for understanding, we're after the health of Washingtonians, and if we could maybe find out that in relationship to those shift percentages.
So I that's a great question. I just have access to the Medicaid agencies, the pharmacy directors with the Medicaid program. In most states, it's the Department of Health or a comparable agency within a state that typically isn't the Medicaid program that manages, that monitors what you're talking about. So yeah. I don't have access to that information, but Carrie Comer from DOH, we might be able to, I don't know if CDC has some of that information that we could garner that's publicly available, but that's something that we could look at. And I just wanted to mention also that when we're talking about shifting, when somebody's established on their medication and we have a preferred status, we don't make people switch their drug. When we implemented this program, nobody was required to switch. There were some glitches in, the PA processes, which I think we've resolved. And so, and just remember that a lot of the switching is really driven by marketing and the doctor and patient's decisions. But, there are, I see commercials. I think there's not a day I don't see a commercial for an HIV medication, when I'm watching TV. And so, and it seems like when we're during our, the meeting, the month of the meeting where we're going to review the class, I feel like the advertising goes up even more. And so I believe the switching is really driven a lot by marketing, because we're talking about, taking 2 pills once a day rather than 1 pill once a day. So it's not, when we call them multi-tablet regimens, it's not the, handfuls 5 times a day, back in the original ones where it was really difficult to maintain adherence. I couldn't do that. So I think it's a very good idea to figure out, how are we compared to other states?
Just a couple of notes. There's notes in the chat about, will this information be made available? Yes, every slide and will be available to everyone because it's a public meeting. And I might note that Donna, you've just offered up what may be another question. One of the great things that we're doing right here, right now, is defining things you'd like to know better. But one of the other questions is, does moving from a single, I heard 2. One is, are there actual difficulties moving from a 1 pill regimen to a 2 or more pill regimen? And I've heard a lot of, in the 6 weeks, which isn't very long, I've been working with y'all, I've heard a lot of things about that. So maybe that's something to actually understand better. And maybe we could identify who we need to ask to understand that better. The other thing is, is it worth, are you all interested in understanding the implications of marketing? Because there was a pretty significant assertion there that, wow, that change is driven by marketing. Is it in fact? So that may be another question you want to think about. Dale has his hand up, and Amy, I know earlier you had your hand up. And Donna, again, thank you for bringing this information to us. Amy, am I wrong? Was it? I guess maybe it's been asked already.
Hi, Martha. No, I did have my hand up, and I just, my question was really around, it was more of a statement around the shift, and Donna clarified that.
Okay. Thank you. Thank you. Dale, you want to speak again to us?
Yeah, I just want to mention, to follow up, is that pill fatigue is a real thing. And it's not just marketing as a part of it, but pill fatigue when you have a chronic disease is just a real thing that I hear that in support groups all the time, and it checks people out. And so it's a dual role. And do we have any research on that?
Okay, thank you. All right, other questions for
Martha,
Donna?
I don't know that you see that my hand is up as well.
I did not see that. Thank you.
Thanks. This is Commissioner Maroon. I don't think any of us are here today because people willingly choose their pill regimens and change from one medication to another. And I've never heard an advocate, talk against a patient being able to make a decision with their doctor, whether that's based on marketing or a pharmaceutical representative or side effects or additional diagnosis that makes something less workable with new medication they need to take. We want them to be able to do that. That's exactly where we want these conversations to be. I still remember 9 months ago when a provider said that he had a homeless client who would go to a pharmacy, need to go through that PA protocol that was new to him, and it was a frustrating experience, and he didn't feel like he could go back to that pharmacy ever again. So the next month when he goes to pick up his medication again at a new pharmacy, he has to go through the PA process again. And Donna very helpfully said at the time, we can work on that with that patient, right? But that's one person out of a state that has more than 13,000 folks with HIV. This isn't just about 1 pill versus 2 pills. This is about side effects. This is about mental health. This is about certain kinds of people. I mean, I feel like we're having 2 different conversations here. I appreciate the cost of these medications. I appreciate that the state is locked out of being able to tell us what the pricing is because of statute. But we're talking about people here and their experiences and their health. I don't give a flying flip what Alabama is doing. I know exactly what Alabama is doing for people with HIV. I'm not interested in comparing myself to Arkansas or Texas or Oklahoma, although I understand why you do that. But from a patient-centered place, we're doing a lot better in Washington State than many other states with regard to people's actual health on the ground. And I see that health out here in Eastern Washington. I see the people dealing with lymphomas and anal cancers and all kinds of other things on top of their HIV, and they can't manage, a pill at 9 in the morning and then one that at 3 in the morning has to be taken with food if they're also dealing with bipolar. So, people might have only one HIV medication or 2 or 3 HIV medications, but they have 9 other medications on top of it that they're also managing. So let's just be real honest about what the advocates are trying to bring to this conversation here. This is more than money. I don't want us to just talk past each other. I want us to be trying to find a way to come together on this. And I'm not feeling it yet. I want to feel it.
Oh, Everett, thank you for that. And I'm just want to emphasize that your facilitation team asked Donna to bring the multi-state stuff.
Yes, which is fine, which is great.
Yeah.
I do appreciate all that work. I really do. I just want us to also note Washington State does a lot better for people living with HIV than many other states in the United States today.
So thank you, Donna, or thank you, all of you, because all of you are a part of that. The other thing is this conversation is mixing up all of these 4 bullet points. And Scott, in addition to having his hand up, maybe with the question, also had information to bring to us comparing other states. So Scott, I don't know which of those 2 things or both you wanted to offer us just now. And again, if I miss your hands being up, I appreciate you calling that out, or also call out Omar and he'll help me facilitate better. Thanks. Scott? And for some reason, Scott, you are still muted. It doesn't look like you are, but you sound like you are.
It's the double mute button. It's the microphone and the mute. It gets you every time. But, to echo Everett's conversation is that we are talking about multiple evaluations to this process, right? So cost is only one indicator to this work. It is the qualitative data and that we are actually missing about all of those things that Everett had talked about. So it's to what degree of, does this restricted formulary affect the potential for delayed receipt of care or the delayed access to patient and provider preferred and potentially more effective treatment? And the results that affects a person's disease progression, right? So how quickly they get to viral load suppression means whether or not another individual could have been affected by that individual as an index patient, right? So if there's an onward transmission of HIV, and we know that there is possibly 40% of individuals with HIV who may not be able to achieve viral load suppression and could pass that on for whatever reason. It could be all of the things that we're talking about here. It could be pill burden. It could be the fact that they are not with a pill synchronization, right? So you get 2 pills that you may go to the pharmacy, but you may only get one on that day. And then the next day you may have to come back for the other. In the meantime, you cannot take only one pill and then just follow it up with the next day. So there's concerns about resistance. So it's that qualitative data that we are sorely missing. And I know that cost is the consideration for this, but it also should be people's lives in that respect and how long it really does take them to reach viral load suppression in that. And in fact, we have some backdrop to Medicare Part D, which has a protected class, which requires under Medicare Part D that all these individuals, these medications are covered, period. But there is a difference that we're having with Medicare versus Medicaid, and there isn't a universal understanding. So I do want to say that, that is getting lost in this conversation of cost. It's the patient-provider relationship and that decision-making piece of it. And without that level of data, by the contractors, by the care coordinators who can provide this information, I think we're missing it and we're focusing solely on cost. I did have my hand raised for one question on Donna, and this was a great presentation, is whether or not that switch rate rationale, if it is factoring in the gross price or if it factors into the net price after the rebates. So I was curious about what that was. And then I can show some slides too.
Hi, Scott. So that's net of rebate. It was net of rebate.
Net of rebate. So this that factors in
Net
what
cost.
that would actually be.
Yep.
Okay. Thank you.
Scott, before you show your slides, I just want to say Manny and Renee and Omar and I are collecting things to move on with. And you said something just a moment ago that I think is really important. You said we need the qualitative data. And then toward the end of your conversation, you said you can get that by speaking with, I believe, I can't remember if you said case navigators or people who provide the care or people living with HIV themselves. Can you kind of give us the boom, boom, boom bullet item of how you would choose to get that qualitative data if you could? What would you do?
I think one way that you can do that is to reach out to the Title 19 Medical Case Management Medicaid coordinators, which are the contracted providers who provide that case management services, who are at the front line of helping a client through all aspects of their individualized service plan, to include viral load suppression and adherence. So I think in talking with places like Lifelong or PCAF or Blue Mountain Heart to Heart, we could get to some of the case managers who review their case notes to see how often someone has tried to switch from a 2 burden because of pill burden that may be notated in case management notes to a 1 pill, and whether or not there was a lag time in between how long the prior authorization took and how many times they had to go back to the provider who may have just actually given up after the first time, after they realized it could have taken more than 24 hours. These are individuals who often lead very complex and challenging lives. So I think we could get some really good data by talking to our contractors about some of the challenges. And I'm not sure if you can see my screen here.
We can. A lot of text.
Okay, it is. And I'm happy to send this to you, but this was some of the conversations that would echo what Everett was saying and what many others are saying. So you can certainly see this aspect here.
Okay.
But I can show you what other states are doing. And quickly to Alabama, actually Alabama doesn't restrict any medications whatsoever. So they take a different health equity lens approach. And it may be that individuals within those states are more often marginalized, persons of colors, realizing that they have a higher degree of burden to go through to get 2 pills, let alone 1 pill, let alone 2. So they've taken a different route. But
Scott, this is a question for later. I'm wondering if you and Donna are drawing from the same sources, but let's go back to that later. Never mind.
Yeah, I bet you we are. So a lot of this is, as you can see where it is, it's drug utilization data that's reported by states for covered outpatient drugs that are paid for by the state Medicaid agencies. So this is directly from the Medicaid.gov, and this is the URL. And we went through and started compiling that for you. And I looked at 3 years, right? So we looked at 2019, 2020, and 2021, knowing that we're only in really kind of Q1, Q2 of 2021 data. So I wanted to make sure that there was a combined 3-year subset of data, but it all comes from Medicaid.gov with respect to the drug utilization data there. And we looked at states that are restricted and that are non-restricted. And primarily the products that we're talking about are these 12 medications, which are single tab regimen single tab regimens. And whether or not they're comprised of a 3-drug or a 2-drug, they're still often the single. So with that, we can first kind of give you just an outline of this. You can all see this later, and I'm happy to share these slides with you because it's really hard to see as we remember what the acronyms for all of these things are throughout this presentation. 2DR or 3DR is just the same verb as 2-drug or 3-drug. So when you look at a tripla, that's a 3-drug. If you look at Complera, it's a 3-drug. If you look at Dovato, it's a 2-drug. So that's when you see the acronyms here. STR is considered a single tab regimen, and NNRTIs and RTIs are just non-nukes and nukes. And I wanted to make sure that you put in the life cycle so that you could see where they stop it in the replication process. And then integrase inhibitors, BS is booster, and then backbone is backbone, and then PI is PI, and it goes through all the products, and I've outlined them for you so that you can see that. And then we can just do an absolute analysis across the state of Washington versus all other states relative to this information that I accrued. And you can see in orange, which is a 3-drug, and then the really low blue down here, which is a 2-drug, most of the states outshine us with respect to their usage of single tab regimens. Here's Washington's. In 2019, Q1, Q2, Q3, and you can see that there is a progression upwards as the healthcare authority also went from a fail 2 to a fail 1 during the same time frame. So at the beginning of this process, we had a fail twice. You had to fail 2 medications before you could get access to that. And thankfully, the HCA took that and we started to this fail first or fail once. So you can see a climb upwards in the orange, and then really down at the bottom, the 2-drug. It's because there aren't many that came along in that that time frame. And really, when we're looking at the 2, it's Juluca and Dovato. So you can see way at the bottom the little blue. But when you compare this to the orange, you say that we have a lot less usage of single tab regimens versus all other states. Then I broke it down to each individualized state as to how many medications are restricted. And at the top of that list is the state of Washington, followed by Idaho, followed by Mississippi, Virginia, and you can see below and how many they restrict of these medications right here. So you can see that we are far behind many other states that have their own health equity challenges. And as we're looking at cost, again, it should be in terms of cost with the consideration of not just the clinical efficacy, but of the personal and the qualitative data that is necessary to make these determinations. And unfortunately, when we talk with the provider and therapeutics and the Drug Review Utilization Board committee, they look at it through the lens of clinical efficacy. And that may truly be the case, absolutely. But how does cost factor into their clinical considerations? Because when we were looking at the cost of one particular drug that I'm not going to outline through the IBM's MicroMedX Red Book that gives cost, one of the single tab regimens is actually less than many of the other single tab regimens that are approved for the state of Washington. So I know that we have an MOA with the PBM that excludes that, and that statutory rebates don't necessarily apply to that one medication. So their incentive is exactly less to include it. But when we're looking at it from just a cost transparency issue, it's less money, but it's not included. And the reason being is because they don't get statutory Medicaid rebate dollars. But if we're talking about clinical efficacy, as well as personal and provider decision-making and health equity and all the rulings that Medicare has on and the time to reach viral load suppression, then it would presume that this medication would be included if you were looking at both lenses, but we are looking at in terms of cost and that they don't have the statutory rebate look at. And in fact, also, we're also going against what we did at really proudly with the Office of Infectious Disease and the Department of Health and the Healthcare Authority. We came together as a community and we looked at the Bree Collaborative Minority Sexual Health recommendations. And one of the areas that we adopted was that we adopted areas requiring LGBTQ specific standards and systems of care and treatment that outlines that healthcare providers should follow U.S. Department of Health and Human Services guideline for the treatment of persons with HIV, which means that all clinically approved medications ought to be included in on that formulary if we were to look at it from a cost, clinical efficacy, and a health equity lens. So I would say, let's go back and actually review the great things that we did and talk about health equity, not just in terms of cost, but in terms of all of these other issues. I would also say that, and we're happy to go back to each of the states to look at which ones we can go at an absolute analysis that you'll be happy to play with as you take a look. You can comparison shop, but it will always stay the state of Washington up in the corner. So if you just want to look at, say, like Arizona, that might have a similar demographic profile with respect to transmission rates, you can see that their orange is higher and their blue is higher. So it says that they are taking that health equity lens as well as a cost consideration approach, and their legislature is looking at that to help to backstop the cost consideration. So you can play with that a little bit. It will always say up there, state of Washington, like I said. You can also look at restricted states versus non-restricted states and see the comparisons. Then you can do very similar as that. And then here's just the raw data. If you're really, really interested in looking at that and finding out the NPIN numbers, which are the provider numbers. And then I would refer you back to some other states that are in our Western territory, right? So Oregon just recently did a prior authorization review, and they first reviewed it in 2015 when there were more challenging cost times. And they looked at that, and all preferred drug medications were included. And at the end of the fourth quarter of 2020, they too looked at it again and made no changes. An analysis in California actually found 3 things that prior authorizations actually do to a patient that's waiting for this new to market drug so that they receive a new indication that's approved by the FDA, medical necessity, which is a prior authorization. They found out that they negatively affect individuals' access to PrEP. And PrEP here is a great breakout, because we do not necessarily presuppose that 70% of individuals will switch potentially from the generic cost to a name brand drug, right? So there is not an apples to apples comparison that 70% will switch because they do it on the treatment side. That is not necessarily the case on the treatment side. So you have to take that with a little bit more of an appropriate lens through that. But ultimately, they found out that prior authorizations, they negatively affect access to PrEP. They also find it affects their adherence to their PrEP. And it also undermines the HIV prevention efforts, which is part of the NDAIDS Washington platform. So I will leave you with that and this data that you can take a look at. But quickly, just when you're looking at it, just in terms, why is Washington state number 1 across those sums of restricted if we are only looking at it in terms of cost without this clinical and the health equity side? And that's all.
So I have 3 facilitator things to do here. One is to note that Beth and Donna both have their hands up. The other is we're doing exactly what we thought we might do, which is this agenda is getting full of information. So I'm going to address that in just a moment. The other thing is, this is a lot of complicated analysis. And what I'd love for us to each do, I have the benefit of being married to a scientist. And one of the things my scientist spouse does all the time is relish people taking a deep and aggressive dive into the models. And I think that's exactly what we're going to do. I don't want I want everybody to approach this from the perspective that people work with numbers and models in a way that brings assumptions that come from their perspective and their background, and that taking a deep dive into them is exactly what we need to do from all perspectives in order to get at the heart of how we can advise the legislature to make appropriate policy decisions. So with those as my three facilitator things, we're going to hear from Beth and Donna, and then we're going to take a 10-minute break and we'll come back together, see if we can, we haven't had a chance to give you an opportunity to ask Chris anything yet. So there's that too, if you can stay with us, Chris. And then we're going to use all of this rich stew we've been stirring up here to see if we can coalesce the things we'd like to begin thinking about for your report. Beth.
Thank you. You know, I have to say to what Scott has said that, and to speak to some extent to what Everett said early on, and while I may not be exactly on the same page with Commissioner Maroon's response, I do agree that these state-by-state comparisons are problematic. And I think to be honest with you, what I've seen from Scott, and particularly a comparison to Alabama, I think is very problematic, because I think when we're talking about health outcomes in our state for people living with HIV, and you put the care continuum and the viral suppression rates and the retention and care and the diagnosed HIV cases in Washington state up against Alabama, regardless of what's on their Medicaid formulary, you are not going to see the same health outcomes. We have a much more advanced program here, and we have greater health outcomes. We are still not making the mark, but I believe that where we're going with this state comparison can be very problematic and actually not tell the whole story. So one of the things that I would like to offer, and I'll have to talk with Donna and I'll have to talk with our surveillance team to be able to verify how long it would take us to do this, but I would like to be able to show, and I can tell you absolutely, I can only go back to 2019 because our 2020 data is terrible as a result of COVID and not reliable. I can go back to 2019 to show viral suppression, and I believe I can show statewide viral suppression, and I believe I can show Medicaid viral suppression for you to have a state-specific, real understanding of how Medicaid patients on Medicaid are doing in their care continuum compared to the whole state. So I would like to offer that. If we're really going to focus on the health outcomes of people, I think we have to do that, and not these state-by-state comparisons that to me are often invalid.
Absolutely, that would be, I think that is such a great idea, is to get that health utilization data as related to where people stand with their viral load suppression. But it's also, I think, important to get the qualitative. But to the original point of you pointing out Alabama, I was simply responding to what Donna had first pointed out when she mentioned Alabama. So I was just simply showing that. I didn't show a health utilization viral load suppression metric or the care continuum. I was responding to what Donna said initially.
Right. I guess I'm responding to the fact that you're pointing out as Washington being the worst, and I'm saying that's not an accurate statement.
In terms of restricted access, yes, that's all I'm pointing out. I'm not, again, I'm showing here just what other states are doing. And what I said right here is exactly what you're saying is, here's the qualitative data that you're missing. So it is fantastic that we're stepping up to see now what that health utilization data may be, but we have asked for that for a period of time with some questions still remaining. So mine is simply just the comparison, which I was asked, and there's no pejorative there whatsoever. I value absolutely all the work that is done at DOH and at the Healthcare Authority on that level.
I'm also I guess I'm a little confused too to the document you have up. Can I understand, or is it in here, the source of this information?
Put myself on mute. Yes.
Okay, so I see the state utilization data the comments of the previous slide that you had up, Scott, where you were talking about the California study and the Oregon. Where are the sources on that?
It's in your questions sheet.
Oh, sorry. Go on.
It's in your questions sheet.
Yeah. I can source trace that for you too. Absolutely. But it's not. I mean, it's an easy source material for the Oregon for their recent review. So I show the two just those two metrics there for the questions. I can get out of this.
So facilitator hat here, Scott, we use the word worst, and it's about one of several things, one of several measurements that can kind of go right to the heart. But again, as Manny said at the beginning, we have passion here and we're coupling it with compassion. So we're having rigorous conversation and we're getting to the heart of the things that need to be discussed. Appreciate that. Donna.
Great, thanks. So Scott, I wanted to correct something that you mentioned. The costs that are published in the Red Book are the wholesale acquisition costs for these drugs, or what we call the list price. It doesn't mean, so when you look at that drug that was less expensive but not preferred, it doesn't mean that that drug doesn't get a Medicaid rebate. It actually does, but it can't be listed in that Red Book. So the what you're seeing in that Red Book and what you see publicly are not reflective of what Medicaid prices would be. So you really cannot compare the list price or the wholesale acquisition cost and look at what those drug costs compared to my net price. Because you'll see like Truvada and Descovy look like they're about the same price as their list price, but Truvada is, almost free to the state. And it's actually, the brand is actually less than the generic because of the Medicaid best price and what Chris's presentation showed you about that CPI penalty. So I just wanted to point that out. So when we're looking at costs, you really can't look at what's available in the public arena. The second thing I just wanted to clarify is we've never put Truvada on prior authorization for PrEP. From the day that it hit the market with that indication, Washington State has always allowed open access to PrEP. So I just wanted to clarify that. And we didn't put Descovy on prior authorization until the clinical committee agreed that not everybody needed to have open access to Descovy. And so we put that on prior authorization a year or so ago. And then I wasn't sure what the data that you're presenting, is that fee for service only data, or does that include managed care data?
It includes both.
Okay. Because
it's into the raw data. So if you want to take a more meatier dive. Okay.
Because I was just, wanted to point out that if it's only fee for service data, we have a small percentage of our population in the fee for service program. Right. So just wanted to point that out. And then I think to add on to what Beth was saying is that the way that you were presenting increased to, having more single tablet regimens preferred without restriction is better. And I think we need to be very cautious with making those type of statements without the qualitative data that you mentioned, because I think it really is misleading when we make those statements. And so
absolutely.
And so I would love to have, the conversation. And I think what we really want to focus on is it really the fact that we have prior authorization period, or is there something in the process of going through the process to get authorization? Is that really what we should be focusing on? And is there something that we can improve upon? Because we don't, the state is not in the business of trying to, restrict access in order, for the people that really need the medication. So if there's something, we changed our policy to make it we have this extremely broad, I need to change one of the words because I think it's more about autism. But what we're trying to make it was so that people that had, mental illness could get their medication without having to, try one of the non-preferred drugs first, or somebody that maybe they have substance use disorder and they just really cannot manage their day, activities of daily living. And so if that's where the problem is that, for those few people, and I'm saying few relative, there's a small population or a subset of the people living with HIV population that are probably more impacted than others. And if there's a process problem, let's focus on the process or that subsection of the population that we can, make sure that we're not, providing, really to make sure that we can get them through the process and get them the medications that they need.
Okay. We've taken a big deep dive and we're going to take a 10-minute break. Eric, can you be with us for another 20 minutes? I'm sorry, Chris Andrews. Can you be with us for another 20 minutes?
Yes, I intend to stay for the duration.
So a 10-minute break. We'll be back together at 11:17, and we're going to wrap up these clarifying conversations, which have also generated a whole lot of ideas about what can be done. And then we're going to do the brainstorming session that, as Manny introduced us all to, is all about creative opportunities to both learn enough so that we can have creative solutions, and maybe there's some creative solutions right at hand right now. And so that's what we'll gather together in the last time we have together. Okay, see you in 10.
And Martha and Renee
Yes.
and Omar.
Okay, welcome back, folks. When you are here, if you could turn on your video so we know when people are back. We took a little longer in the staff room than we had imagined we would. So I should know after 30 years of doing this that a 10-minute break is really not long enough. So thank you for your patience. So as you arrive back in, if you turn on your video so we know you're here, we can get started again, and you're welcome to turn it back off again. Right. So as we wait for people to re-arrive, just a reminder that what we're going to do is give you all an opportunity to ask Chris Andrews any questions. And Manny's going to do his wonderful raconteur work of summarizing some of the key points that you all have generated in this shall we call it a spirited discussion? And we'll use that to build on more brainstorming on what actually goes into your next steps. So we're waiting for Melanie and Amy and Eric, but I think maybe we're going to go ahead, Chris, if that's okay. Who has, boy, it seems like it was 3 months ago, Chris, when we were looking at your very informative slides about rebates. I wonder if any of you have questions for Chris about rebates. Yes, Beth.
I don't have a question, but I'd appreciate it if he could speak a bit more to the confidentiality. I know that's been a topic in this group. And I know, Chris, you mentioned that it's in code and a couple of other things, but could you clarify that for the group a little bit more? Because I think that is an important issue that we've discussed, and I want to make sure everybody is understanding that because it is multi-layered.
Sure. So as mentioned, it's in U.S. code that it even protects the participation of, it protects whether or not a manufacturer even participates in the supplemental rebate program, federal rebate program. So yeah, thanks, Donna. Section 1927 of the Social Security Act, if anybody wants to dig deeper into the description of rebates. The protections in there are for trade secret purposes, and of course, there are exceptions to them, but they are really on a need-to-know basis. I mean, for example, I've been involved with discussions where state legislatures wanted access to the rebates to be able to do this kind of work, and that was declined by state attorney generals and supported by manufacturers. The agreement between the manufacturers and the states are typically upheld very strictly. So it's a very, very specific need that needs to be approved by both of the parties to the contract before any of that information can be shared.
And Chris, what are the penalties for breaking that code or sharing that information in a not a need-to-know basis? Do you know that?
Good question as to what the penalties are. I don't know what the specific penalties are, only that they're protected by federal law. I have seen lawsuits before between states and manufacturers, so it does go to that extent. Donna, I don't know if you had anything to add. I saw you chatted and raised your hand.
I'm not sure. I'm not sure if it would result in jail time. It probably would depend on the level of the severity of the disclosure. I did have I present or created a couple of slides very similar to what Chris had, but I actually copied and pasted the actual language from the statute. If anybody wants to see it, I can display those slides.
You know, at this stage, maybe we could make sure those are available to you all through the portal. Let's hear from Dale and from Jonathan.
Yeah. I'm traumatized as a human citizen of Washington State to not know these rates. And I want, what is the psychological impact of non-transparency of these kind of non-disclosure agreements? And we're all adults. We all, you know, and we should have, because it helps, it sort of helps relate to how do we plan? You know, and look at costs and what cost am I to the state of Washington and to my fellow citizens? Because that might be an impact of how I look and take my medications. And this is an impact. It is a trauma piece to this whole the conversation and where we're trying to evolve to. Is there a healthier way that we can evolve out of that? I haven't heard that yet. I suggest that. I'm really, it's like, can we go to higher standards with it? You know, it's not compassionate at all. You know, and that's our charge here today. And it's not a compassionate, and I know no one here made the law, but how do we represent it and how do we move forward? I don't know the answer, but it is sure trauma, because I'm a citizen that I don't want to bring additional costs. If I can save costs to my fellow citizens that are paying for my, you know, my medications and such, I would like to partake in that. And we should encourage that with our fellow citizens in general, you know, and to participate in, you know, and lean in, you know, how are we doing this thing called life?
Thank you, Dale. Jonathan.
I had a question for Chris, I guess. And I'm sorry, you might have, Jessica, covered this and I didn't quite hear what you said. I'm curious to where the line of confidentiality lies. You mentioned the information is on a need-to-know basis. You also mentioned cases where legislators requested the information, and are you able to share with legislators given that they oversee the state budget? And then I'm curious about other agencies too, other state agencies, for example, the Department of Health and the LGBTQ Commission, you know, legislatively directed work group like this one. Sorry, those are examples of others who might want or need the information. Are they allowed under federal law?
In my experience, the rebate information, of course, is held tightly on the manufacturer side. On the state side, that's where we get into more of an interpretation of who needs to know. Legislators frequently ask, and states frequently do not extend the rates that far. So for work groups, for legislators, I generally have not seen the rates shared at that level.
Okay, let's hear from Everett.
Thank you, Martha. I don't think we're going to change federal law anytime soon. You know, we could have a conversation about how people interpret this confidentiality, but you know, as a practical matter, it is what it is, and I think we all have to work around the limitations. What I'm wondering is really I've got a question possibly for Manny or Martha. Are we coming toward a point in our next meeting where we're going to talk about how we're going to address these issues? Because we've heard a lot about cost considerations. We've heard many appeals to the human side, the client side, but I haven't seen any discussion yet on how we're going to resolve this. And there seem to be no offers on the table or anything. So thank you.
That's a very good question. And that I'm going to call that a segue into our next segment. But before we go there, we've got a couple more hands that are up. Dale would like to speak again, and there may be someone else. Do you have your hand up, Carrie? Or you, oh, okay, you're like me, you're rolling your, yeah, okay, got it. Dale.
Yeah, I think Scott was first, Martha.
Oh, Scott, okay, Scott.
Mine's very simple. It was just, you could get the contract itself just to see what it outlines, right? So you could get some glean of information as to not the contents of the conversations, but you could get just a look at the contract to see what the parameters are and how that's outlined in between the two. That was all.
Okay. Dale?
Yeah, just quickly, you know, I know that Medicaid has the 42 CFR 431.51 about free choice of providers. And inside of that, it says about free choice because of maybe the provider is not meeting up to the mental health or to the cultural, you know, sensitivity or such. And so could that be something that we roll free choice of prescriptions into? Just an idea.
So as a suggestion, just as Everett said, we're not getting to solutions yet. There's one idea. Okay. Roll in. I'm just taking a note here. Okay, with that, we're going to move to the next segment. And I'm going to give just a little bit of prep for what we're going to do. And then Manny's going to coalesce some of the solution-oriented thinking that you all have in fact been doing in the midst of like I said, a very rich stew of numbers, passion, facts, history, and experience. So what we're going to do next is we're going to take a look at the 3 areas that were asked for this work group to look at in the budget proviso. And we're going to brainstorm on topic areas and solutions, context and content for your report. Now, coupled with this is I want you all to have the knowledge that your facilitation team is going to take what we've been calling the blueprint for your report. And we're going to take what you do in the next hour and rework it again. And this time we're going to ask you to really look at it between, I don't know when we'll get it to you. I'm hoping by Wednesday or Thursday of this week, but we really need you to look at it and come back to us. I think we said September 28th. So to do exactly what you said, Everett, to start saying, okay, what are we actually going to eat out of this rich stew? So that's what we're going to do next. Manny, you want to launch us into that?
Yeah, Donna, do you have your hand raised?
I do.
Yeah.
And before we come to solutions, I don't think we agree on what the problem is. And so I find it really difficult to try to solve a problem where we're not even sure. One, there's no data to show that there actually is a problem. There's a perceived problem. And so how can, and we can come up with all kinds of things to do, but what is the problem we're actually trying to solve? And is it really a problem? Because I haven't seen any data to support that patients are getting turned away, that they're getting delay in care, that this is impacting their ability to get to suppression rate. So I feel like it's a little premature before we get this data that we're talking about, you know, that Scott has requested, and to make a recommendation on a policy change for Medicaid.
Okay, 2 things quickly. First, let me offer that when I say solution, I meant that in the very broadest terms, which could include what's other information we need to know. I also think maybe it's useful as a part of our next conversation for people to say, what do they think the problem is? That could be a useful part of this. Let's hear from Dale, and let's hear from Manny.
Yeah, hey, Donna, I mean, I appreciate all the efforts you do in our state, and for me, it's the issue is it's not equitable. It is not equitable, the prior authorization process. Healthcare Authority oversees, the prescriptions also for the state employees and for these other and here we have the low income getting a secondary standard of access. Okay, that is a problem. That is not equitable. Okay, and it's like the system is not equitable, and that is, and I can talk about the traumas of last December. And I'm sorry, everybody, but it's like we were told this was being impacted or put through because of cost. But then now we've got new programs coming out of the state, and because we didn't have that cost, and it was like, well, that was how do we justify that? Back to equity, though. It's back to let's look at the transparency and how we treat each other in our state.
Thank you, Dale. Manny.
No, thank you, Dale. I want to say something, and I think that is important. I have to say a few things. One is I do want to recognize Dale for sharing his vulnerability with us. I think that is so important to listen to people for whom these decisions are created and these processes are put in place. I think that, and that speaks to some of the things that we have been saying, to center the human experience, to center the need of Washingtonians who are currently living with HIV, who are also receiving Medicaid. And I want to acknowledge that we can go on a bunch of different issues and a bunch of different routes, because it's not only the people living with HIV with that access healthcare through Medicaid. It's also everybody who lives with HIV, everybody who's impacted one way or another, caretakers, community organizations, and whatnot. The other thing that I wanted to say is that I want to recognize that we have different ways of expressing our ideas, our frustrations, our celebrations. And I want us to keep that in mind, while at the same time being conscious of how our words, regardless of the intention that we have behind those words, how those words impact people. Dale, you have been very vulnerable and very open with us, and I want to make sure that that when people hear what we say about people who are living with HIV, that their experiences are centered and highlighted and recognized as valid, regardless of what the hard data says. And I'm going to say it like that. Regardless of what the hard data says, we need to recognize that there are humans behind each and every one of these realities. With that, we have already heard many things that are pointing towards some of the things that we're going to be including on the report to a legislature. Why? Because, as Donna was mentioning, we don't have a lot of data on a specific subgroup on the intersection of different realities, right? Like people who are without permanent housing, people who are moving from place to place, people who are with multiple health issues that affect the way in which they receive treatment. And we need that data. Now, it is important to remember that the instructions from the legislature are not necessarily to find a final, solution to these issues. Is what are the ideas that you have, that we collectively have, to address those concerns? So it might be that we are not going to be able to say at the end of our work together, these are the 4 things that you have to do to open access, to facilitate. And I'm not going to say open access because I know that has a different connotation in this context, but that we can facilitate better access to these particular drugs. Okay, so we might not have the final, answer to that, but we are going to have very concrete recommendations. And for instance, a few of the things that we have heard so far is we need the resources to collect the qualitative data that is going to inform how the processes are put into place, because that is lacking. And what I heard from all of you from different perspectives is that without that information, we don't know what the conclusion is, because we have people who have experienced certain things, but that experience hasn't translated into data for the people who are making the decisions on how the medications are available to the people, and then to match that with the processes that the federal government imposed to states on how to utilize Medicaid and these processes, and also what pharma does to mitigate the cost through rebates and all that. So it's very complicated, but at the same time, we are getting some of the solutions and some of the recommendations on how to address concretely these concerns. So to point out about, to make a mention about something that I believe that both Everett and Donna have brought up is, what is the problem? And I think that that's one of the reasons why we are having these conversations. There are multitudes of problems related to these access to medications, and we want to name those problems and name possible ways in which we can address those problems so we can find concrete solutions. That's a lot. I'm sorry that I took on with all that. And we only, on today's meeting, we only have 15 more minutes, actually. So we want to start collecting ideas. And I want to say there are no wrong ideas during a brainstorm. The reason why we are going to have town halls and more of these work meetings is because we want to refine those ideas. So if you have an idea today that, from your perspective and from your experience, it might cost $10,000 million, that's okay. That's a good idea for today because it's a brainstorming. We are going to take the time to start collecting some of the ideas, and through the process, we're going to start refining those ideas. And through the town halls, we're going to get feedback from the community itself on those ideas, so we can start drafting and crafting the report. I see that Eric had her hand up.
Thank you, Manny. I just want to start by saying, one of the issues that we're having in this group right now is a gap in participation, and that is providers. So what we know from what we've been hearing from providers who talk about the problems in access related to prior authorization and fail first policies, that those are really getting in the way of people accessing their medications. And so not having that set of people here to talk about the direct impact that is happening for people living with HIV is, I think, a gap in our conversation. And then the other thing that I wanted to bring up is that we really need to center our solutions on the people who are furthest from justice and furthest from access. And that's the folks who are not virally suppressed, the folks who have the least access. When we talk about how successful Washington State is, and we are among the best in the country, and we should applaud ourselves for that. And there are still folks who are slipping through the cracks of our system. And that's who we're talking about, and that's who we need to center in our solution making. When we do that, everybody else is going to benefit, but really focusing in on how do we ensure access to those folks who we haven't been able to reach, who are still virally unsuppressed. That's where we need to go. Thank you.
Let's keep at this for about another 7 or 8 minutes. And know that we've captured the ideas that were brought up during the information segment.
Jonathan, Martha, if you want, so to make it a little bit easier, I'll pay attention to the hands and call people in so you can type. Okay.
Okay.
Good. Okay.
Good.
So Jonathan, I saw your hand.
Thank you. I think I agree with what Eric just said about providers giving input on this process. That's something that I and Cascade AIDS Project are working on, but I want to note that I think it's a little bit harder for a community organization to do that outreach than it may. What am I trying to say? I'm trying to say that I think most people in this room can help bring in those voices. The same, I would say, for case managers. To date, as far as I know, outside of DUR board meetings, the only formal input from providers was through the clinical advisory committee that the Department of Health put together toward the beginning of this process. But that was a relatively small group. So I think it would be valuable to bring more to bear on formally including things like a survey or a set aside dedicated portion of a town hall or a town hall to those groups.
Thank you, Jonathan. And Carrie, Comer, and I and Omar are actually working or are going to start working on scheduling time with some of the providers that we already know have been involved in the conversations. In addition to that, I want to extend an invitation to the same invitation that I've extended to those physicians and nurses and practitioners. But if you have names of people that we should be contacting, send them to me, send those names to me, send that contact information so we can start scheduling time with them to get them to offer their perspective and their ideas. So, and that includes social workers and anyone that provides services to people living with HIV that we should be listening to. So, in addition to that, Renee has a more formal invitation to the town halls, but just to mention it quickly, that's also an opportunity for healthcare providers to be engaged in the conversation. So keep that in mind. Everett, you had your hand raised.
I just wanted to throw in another comment in here about the kinds of data that we've been looking at and the kinds of data that might be harder to get access to. It's certainly, I appreciate knowing the cost data and some of the policy data. We can look at those things, sort of nationwide. They're easy-ish to find, but the state doesn't particularly do any actual data gathering on some of these soft, kinds of information pieces from clients. Obviously, case managers individually across the Ryan White program put in provider notes. They put in, progress notes on clients. There may be comments in them, but it would take a lot of culling through confidential information to find how a schedule change on medication would impact a specific client, and then pull that out to an aggregate and see, is there something that's a larger picture here? That's why the state uses things like CD4 counts and viral suppression rates, linkage and retention and care to create a overall picture of the health of people living with HIV as a class. So I really want us to be open-minded to the fact that some data are easier to find than others. Doesn't mean that because we haven't seen something that issue doesn't exist. Working with clients living with HIV for 11 years in Washington State, I will say we do see problems with late diagnosis. We do see problems with compounded, diagnoses among our client base. WSU did a wonderful investigation in 2019 that showed that people in Eastern Washington have a 5-year less life expectancy than folks in Western Washington, west of the Cascades. So there are some data out there if we want to pull them in. I just don't want us to close off to, well, I know these data well, and so from my perspective, this is the only way reality looks. Let's keep an open mind about things other kinds of people might know to bring into this conversation. And please, let's all be prepared to move from our initial stance coming into these conversations, and have some compromise on all sides so that we can improve access for everybody. Thank you.
Thank you, Everett. Amy.
Thank you, Manny. One of the things that I've been wondering as we're sitting here listening is really, how do we bring in providers to the discussion, but also the providers of other chronic diseases? Because we're really talking about, providers that this authorization or the step through therapies or things like that is kind of new to them, because they haven't had a lot of restrictions applied in the past. But if we're really moving towards recognizing HIV as a chronic disease and getting rid of some of the stigma around it, I really think we need to hear from providers that have also helped other communities navigate through authorization processes, or find out how those chronic illnesses are managed as well. And then glean from that some of the nuances and possibly see how it applies to our current community that we're speaking about.
What a great idea, Amy. Thank you so much. Melanie.
Thank you, Manny, and thanks everyone. I could not agree more with Eric about centering those farthest from care. I think that as our audience is going to be the legislature, the legislative process is a little bit constraining in that they usually just look at the costs of something and they don't look at the surrounding averted costs, right? Like famously, they'll cut birth control coverage and then be surprised when pregnancy costs go up, right? And so I think it might be really useful to look at data around adherence and the ability to adhere to a regimen and the following healthcare costs that may follow from that barrier, right? So if that means increased hospitalization or increased need for other therapeutics, or I just think to the extent we can, we should provide more information to the legislature around sort of the life cycle of what this individual is going through. And then secondarily, also around data, to me, one of the problems that must be addressed is that our HIV infection rates are going up. And that is one of the things that makes this different than other chronic diseases. This is not actually a chronic disease. It is, but it also functions as the pandemic that it has been for 40 years. And so I think to the extent that we should understand what the lifetime costs are of new infections, that should be inclusive in our report to the legislature so that they have all of the dollars, because it may be that they want to make the decision to save the $10,000 now and then incur the $1 million lifetime costs, or they might, and I'm just pulling those numbers out. But I mean, I think that that's the kind of data that the legislature needs to have is okay, this might be a short-term investment, but does that help us avert the public health impacts for the next 40 years? Because my understanding is that rates are going up and that people are living longer. And so I think that it's great people are living longer, but if you're a legislator writing a budget, that's information you should have. So thank you so much for putting that on your list. And thank you so much for this discussion today.
Thank you, Melanie. Eric, and before Eric speaks, this will be the last the last question or suggestion, because we do want to move along, and just a reminder that this is not the last time that we're going to be getting suggestions and recommendations and ideas and concerns. Remember that you can always reach out to me and send pages if you want, and if you have of recommendations, ideas, and concerns. So Eric, go ahead.
Thank you, and I'll just put a plug in for what Melanie just said. I don't have another suggestion, but I do want to call out what I'm perceiving to be a barrier for us moving forward in this conversation, which is that the language that I'm hearing from the state, from all aspects of the state, is really about trying to convince us on the community side that we need to buy into these policies and processes, that I'm not hearing any indication of willingness to move or change. And I think that's problematic, that everything I'm hearing is really about defending the policies, defending the pricing, defending all of that, without any kind of indication that we are actually coming together to find some compromise. And so I think, to me, that's kind of an elephant in the room, and that we need to work on figuring out how to get past that if we're going to actually move forward and find solutions to recommend. Thank you.
So as facilitator here, and as we close up shop, Eric, I'm going to challenge you just a little bit on that. I do hear movement. I just want to tell you, I do hear a little movement, but I also want to reflect on what Manny said earlier, which is when we have both passion and compassion, sometimes it's hard to see that movement, and even if it's incremental and small. With that, I think we need to go to Renee and Manny to close us up. And then this is the last thing I'm going to say, which is watch for the next documents from us. And in order to have an impact, take a look at them. Okay. Renee, you want to talk with us about the town halls? And I believe you may be muted. There you go.
All righty. So I just want to preface this by saying that, for the last 10 years, at least, we have not been able to meet the goals because we've been so grounded in quantitative data. Washington State does well and all of that, but this is language that has been used to justify not putting any kind of energy into communities of people of color. When we get into the numbers justify who can we lose, who can we erase, who's expendable. And the numbers, when we get so bogged down in quantitative data, the numbers always tell us who we can throw away, which is where we're here now. Because what we're trying to do is figure out how to not throw anybody away. So the town hall meeting is about a conversation, but it's about a conversation. In the old days, we used to talk about the communities who are infected with and affected by. And so I urge you to think in terms of not justifying what we have, but actually changing what we have. In order to change what we have, it's very important that we understand really what the problem is and who the problem is affected, and making a decision not to sacrifice anybody in this. And so a town hall, but it requires everybody putting some energy into getting people at the town hall so that we can really understand what's going on with access, with impact. We have the numbers and we can vomit out numbers all day long, but the legislature will be swayed, hopefully, by qualitative data that says what's really going on. And it's just the beginning, but we have to be clear about what's really going on at the community level. It's at the community level that we move from one place to the other. The town hall will be a little more focused on what's really going on, which means that we need everybody to make sure that providers are attending the town hall meeting, and that people who are living with HIV and AIDS are attending, and people who are caring for people with HIV and AIDS, people who are related to people, the infected and affected people who constitute the community of people living with HIV. It's not just the folks who are on Medicaid who are affected by the number, by the problem of people who are on Medicaid having access, for example. So my pitch is to get as many people to the town hall meeting as possible so we can find out really what's really going on, if that makes sense.
Thank you, Renee. I will be sharing, actually, let me put it right here. The link that I just shared on the chat is the official notification or notice and invitation to the town halls. All the information is there. Please, 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 please share that with everyone that you know that is either directly affected by HIV or secondarily affected by HIV. Make sure that people know about that town hall, that we have the opportunity to engage the community. I also encourage all of us to invite people to go through the documents that we have created and shared that have some of the information, especially as we want to make sure that we address the concerns and the questions and the mandate that the legislature gave us. As I said earlier, there are a multitude of problems and issues and challenges. And right now we have to focus on three, right? Impact, access, and I forgot the last one, sorry. So we need to make sure that we are addressing those three issues first, and then bringing anything else later so we can provide that to a legislature as well. Dale, I see that you want to make a comment?
Yeah, just quick about marketing for the town hall. You know, us right here, we're limited to how we can market. And I'm concerned about that because we don't have, you know, and that's been there's a communication, you know, gap to get to potentially the clients that would potentially give the healthiest of feedback. So I'm just going to own that.
So thank you for naming that. I think that it'll be a good idea for us to continue naming things so we can we can work with things. If we don't name the challenges, we cannot work with them, and we try to work around them, and that's not good. So one suggestion that I would have from that might help some groups is if it's safe for your agency, if you are working with an agency, whether it's a public or private or nonprofit, and it's safe for you to gather a few of your clients to be part of the town hall, because it's a virtual town hall, that would be a way for clients and for people who live with HIV to directly engage with town hall. The other thing is that, and I just occurred to me that we can create a form where people can submit public comments, and the documents are on the page, so they can read if they have the ability to read, or if they have readers in their computers, because the system is already set up for people who have visual impairments. So for the people who can access those documents and can offer feedback, feel free to offer that as an option as well, right? Like they don't have to necessarily attend the town hall in order to offer feedback. If you work with closely with healthcare providers, let them know that this is happening as well. If you know administrators in health centers that attend a large number of people, send that and tell them to print that page and publish it on their offices. It's absolutely fine. The more people that we have on the town hall, the better. The town hall is going to be about listening, so there's no like long presentations about data or anything like that. It's about, this is the work that we have in front of us. These are some of the questions. what else can you give us and what else can we work on? So it's going to be, an hour and a half, and of that hour and a half, an hour and 20 minutes is going to be getting feedback from the community. So with that, I really want to thank all of you for taking the time to be here today. I have already sent the dates for the next few town halls. Many or a few healthcare providers have reached out to me, letting me know that either conflicts or that they're trying to figure out their calendars. It's always a little bit challenging. As I said, I'm working with Carrie and from DOH and Omar at the office to make sure that we schedule time with healthcare providers. You can send more information and more people my way. And with that, also, because this is going to be Omar's last day serving in support with us. Omar, sorry, I needed to say that because we have already built rapport with you, but Omar is moving on to the DOH now. And we will have another person working with us, Tracy Carlos, who comes from the LNI. But thank you, Omar, for all the work that you have done with us here. And thank you for providing all the support that you have provided. We look forward to working with Tracy as well. And who knows, Omar, we might see you here again as part of the DOH team too. So he's going to be doing DEI work there. So, and I see that you might want to say something, Omar.
Not much though. Thank you, Manny, for that. And whatever support I might be able to provide in the future, definitely will be around.
Thank you. So, folk, the conversation continues. This is just part of it. I really thank each and every one of you for being courageous, for speaking your truth, for engaging in the conversation. I think that is very important. We will continue doing the work. And in the meantime, Martha and Renee will be, and perhaps I will be reaching out to you with perhaps a request or some questions or things like that, follow-ups. Thank you for all of you who have already sent the copies of your presentations and documents. We will be working on posting those on the website. If you haven't sent them, feel free to send them to me if they are of public, if they can be, shared publicly. And yeah, let's continue the conversation. Thank you so much and have a good lunch. The staff can stay for a few minutes so we can do a little bit debriefing, but thank you all.